Ministry, the Medical Mission, and the Clean Water Borehole Project. The programs are scheduled to be hosted in the city of Kitwe in Zambia and the city of Nairobi in Kenya. In these international mission conferences, Global Wisdom Missions will bring together thousands of pastors, leaders, and ministers of the gospel from both regions to train them in a 5-day school of ministry in the Ministers Training Seminar. Global Wisdom Missions has the vision of reaching out to young Christian leaders, ministers, and pastors with the purpose of preserving the purity and integrity of the gospel of our Lord Jesus Christ. The mission to East and Southern Africa in 2022 will be critical because it will be the first of its kind since GWM was founded in June 2020. Following the pattern of our Lord Jesus Christ of preaching, teaching, and healing, Global Wisdom Missions will undertake additional socially responsive programs to bring healing and hope to the communities struggling with poverty, sicknesses, and diseases. Considering this, GWM will travel with medical doctors and health officials from the United States of America, USA, United Kingdom, UK, and Europe, who will volunteer to offer free treatments to thousands of sick people in both regions. Additionally, the GWM will construct a clean water borehole for the selected villages in both regions where they do not have access to clean water. In view of the above projects, the Global Wisdom Missions, GWM, is asking for your financial support and donations to make these missions and projects a possibility. Find a place in your heart to give your financial and material support to this international mission and charitable projects. Your donations will lighten our burden and make our work possible. We remain eternally grateful for your ongoing support. To donate, please visit www.globalwisdommissions.com or donate via PayPal at wisdomconference3@gmail.com. Thank you.
Right. Good evening, lovely ladies and gentlemen out there. It's always a pleasure to be with you. And tonight, the Global Wisdom Conference is here again, this time with the doctors, and we'll be discussing breast cancer. I'll leave the introduction with my able co-coordinator, Professor Lai, to do the introduction.
Hi, good afternoon, good evening to all our viewers around the world. It's good to come back again to talk about a medical topic. And today we're going to talk about breast cancer. And breast cancer is very common. And I believe that everyone who's listening to us, either you know someone who's affected, a family member, a friend, a colleague, someone who lives in your area, or you yourself may be affected, may have had breast cancer. And so breast cancer is very common, and it's important for us to understand what it is and how it is treated. And today with us, we have two able specialists. So first, we have Professor Rhonda Henry Tillman, who is a professor of surgery and the chief of breast surgical oncology at the University of Arkansas for Medical Sciences. She's an internationally known expert in breast cancer treatment. And we are really glad to have her here. Welcome, Professor Rhonda Henry Tillman. And then we also have Dr. Florence Dede from Ghana. She is at the Kolebu Teaching Hospital. She has several years of experience in treating breast cancer patients. And, she and I were in medical school together. And so I've known her for a very long time. And she is an experienced surgeon, and she is also going to help us delve into the topic of breast cancer. So welcome, Dr. Dede. So I'll hand over to Maud we're just going to dive into the topic.
Right. Thank you, Prof. Lai. So please tell us where you're watching from. So Professor Lai's wife is the first person to comment. Thank you, Mother General, for watching. Please tell us where you are watching from, and please share this link with your family and friends. It's really going to be an educative session, and you don't want to miss out on anything. Yeah, I'd like to know where you are watching from. I think so far we've not had many people log on yet. So please log on. Let me know where you are watching from. Let us know where you are watching from. Share this with your family and friends. Right. So let's start then. Dr. Rhonda, so what is breast cancer? And or maybe let's start from the beginning, actually. How does breast cancer develop? Maybe let's start that way.
Well, breast cancer typically develops when you have an abnormal cell that the DNA structure has been damaged, and you lose the ability of that DNA cell to correct itself, and breast cancer develops. You also can, in about 5 to 10% of people, they can tell directly if they got a mutation from their mom or their dad that can also lead to the development of different cancer syndrome, and breast cancer being one that has a mutation that is associated with it. But most of the time, we don't get to pinpoint exactly where you got the breast cancer or why you developed the breast cancer, other than a cell that cannot repair itself within the breast cells.
So whilst you're on that, maybe let's start off and see kind of how does the breast itself, how does it develop? Because when a child is born, they don't really have a breast developed, and then later on when they get to puberty, then we see that they develop breast. So can you just give us a little bit of the background of how the breast develop?
Thank you for that question, Dr. Laurier. That's very important because actually the breast begins to develop when you're in utero. It begins with a ridge called a milk line, and that develops to prepare you as when you're born, you go through puberty and the changes of hormone changes in your life, which you develop the lobules and the ductal system within the breast. And these changes occur at certain points in your life. You know, when you're began puberty goes from around age 8 to 13, but by the time you're 17 or 18, your breasts have fully developed, and then they go through changes during pregnancy or through the change of life.
I think, Lady Maud, I think you are muted.
My apologies. Dr. Florence, can you hear me? Right. Okay. So I'm coming back to you then, Dr. Rhonda. So,
Okay.
how common is breast cancer?
So breast cancer is the most common cancer in women worldwide. It has surpassed lung cancer. But if you look at cancer, it most common in women. Men can also get breast cancer, but it's most common in women. If you look at the number of cancer cases worldwide, to over 2 million women are diagnosed. And when we say the numbers, it's 1 in 8. By the time you're 80, you have a 1 in 8 chance of developing an abnormal cell within your breast.
Dr. Dede, can you hear us? Can you talk about how common breast cancer is in, say, Africa or maybe Ghana, where you are?
Yes. Yeah, I can. Can you hear me?
Yes.
Right. Can you hear me?
Yes, we can hear you, but you're kind of
All
breaking
right.
up.
Great. So in it's generally increased compared to the developed world. Okay, I'm sorry. Is it better?
Yes.
Can you now?
Yes.
I would say in Africa and Indian is in Ghana where we are, the numbers are not as high developed world. When you take America, Europe, Australia, tend to have more than 2 times the numbers that we have. Issue is that the numbers in Africa, and it's in Saharan Africa have some of the highest rate of injury. When we take Ghana, of all cancers, breast cancer falls. When we look at Ghana, breast cancer comes about 2%. It's cut across the African region. So about cancers, breast cancers, about 30 cancers are breast cancer.
Okay. Sorry about the sound quality, but we'll move on. So, Dr. Rhonda, is breast cancer more common in certain populations than others?
That's a very interesting question. I think that the causes of breast cancer can be related to changes in regions or environmental exposures, but it's a very interesting, but not necessarily. Individuals get commonality versus response to treatment, but it is not. I think that the biggest risk factors for getting breast cancer is one, being a female and an increase in age.
So when you talk about increasing age, so what age groups are mostly affected by breast cancer?
So the increase in risk, any age can be affected, but as you get older, most of the patients we see with development of breast cancer begins in their 60s. The highest risk, the 1 in 8, is in an 80-year-old. So as stated, as you get older, the exposures are longer and the changes in life are longer. So you've had the changes of hormones over a period of time, unless you have a specific risk factor that increases your risk, such as a genetic mutation, which can affect up to 5 to 7% of individuals, where you have a mutation that's passed on from either your mother or your father, and therefore the genetics. These are cancer syndromes. The breast cancer is diagnosed at an earlier age.
Right, thank you. So I want to say hello to Bishop Willis, who is watching from Nigeria. Hello to Professor Audrey from the US for joining us. If you're watching, could you please let us know where you are watching from? Let us know where you're watching from. Right, Dr. Rhonda, so you started us off with the risk factors. So I'm just going to move on to ask you to talk a bit more, and you also talked a bit more about genetic mutation. Could you just elaborate on the genetic mutation then?
Yes, so we know so much more about genetic syndromes than we did in the past. But in the 90s, early 90s, we were able to find that the BRCA1 and then after that, the BRCA2 mutations were associated with increased risk of the development of breast and other cancer syndromes in women and men if it was a BRCA mutation. That means from a hereditary perspective, you get one gene from your mother, you get one gene from your father. Therefore, that gene, if you receive that gene, you have a 50% chance that you would get have a risk for development of that cancer. So if you get one of the mutations, and we know numerous mutations today, actually, we do what we call panel testing, where we could select out several mutations based on 3 family groups of histories from your family and decide whether you are at high risk for having that mutation.
Okay, thank you. So, Dr. Dede, can you maybe talk about the risk factors for developing breast cancer? It looks like she's frozen. So maybe Dr. Rhonda, if you can.
Yes. So there are numerous risk factors associated with the development of breast cancer. And I'd like to just first start out with the two most common risk factor, and I'll keep saying this, and the reason why we're always talking about checking yourself is because being a woman, and with being a female, that's because of your diet, exercise, exposure, alcohol, exposure, all of those causes in exposure to estrogen, and therefore can increase your risk for breast cancer. You can have certain proliferative lesions in the breast. Those are abnormalities found on a sampling of your breast that could increase your risk for later relationship with breast cancer, such as atypical ductal hyperplasia, or if you have a marker for risk, such as a lobular carcinoma in situ, that would say that your risk could be 9 times the risk of someone without that marker. And that's different from a mutation. That is just your sampling of your breast tissue that can cause that risk factor. And then as we get older, that increases.
So, Dr. Dede, let's see if we can hear you better now.
Sometimes, Dr. Dede, it may be better off just turning off your camera.
Hello?
And the audio would be much
All right,
clearer.
Okay, let's try that and see. Is it better?
Yeah. Yes, it is. Can you, do you want to also put in your 2 cents about the risk factors?
Okay, unfortunately, I didn't hear much about what Rhonda said because I was in and out, but yes, I would agree.
Okay.
I think I heard her say at the beginning that being female, that increase in age are the most important. But I wanted to add that in Africa, we tend to see breast cancer at an earlier age. So she talked about 60. We tend to have most of our cases in the 40s, possibly because of our young population profile, but we tend to see breast cancer at a much earlier age.
So there is this thing that, you know, when you're in medical school, you talk about kind of early age of kind of starting menses, and then later age of having pregnancy. Are those things still true as risk factors, that people who have their menses early and then maybe have children later on in life are at a higher risk? Is that true? I think
Menopause late.
Yes.
Yes. Yes, that is true.
So because it's all related to the exposure to hormones. Hello?
Yes, we can hear you. Yeah, go ahead.
Okay, I was saying that, yes, because of the exposure to hormones, once you have your menarche or start having your menses at an early age, and then you stop having the menses or that you reach menopause at a later age, in all, you will have a longer period of exposure to the female hormones. And then also when you have your children, or you start having your children late, or you don't even have any children at all, those are all hormonal risk factors that do increase the risk of getting breast cancer, as well as the use of hormones, like hormone replacement therapy, has also been known to have some risk associated with it.
Thank you, Dr. Dede. You know, you are talking about starting your menses early or having children late. Could you kind of put a number to it? So if you say early, what age is early? And blessings to you, Pastor James Samuel from Kenya. Thank you for joining. Could you give like a number so that if we say early, so that we have an idea? So
usually would say anything less than. All right. Can you hear me?
No, yes. We didn't quite get that. Could you repeat it, please?
Yes, I was saying that anything less than 12 years. So if you have your menses, for instance, at 8 years, at 9 years, that's pretty early. And having children, if you have children older than 25, 30 years, that's late in relation to the risk to breast cancer.
Right. Thank you. Thank you very much for that. Hey, Pastor JPC, thank you for joining. Get your people to watch on YouTube with you. It's good to see you. Keep sharing the video. Thank you so much. Right. Thank you. So let's move on then. So, Dr. Rhonda, how does breast cancer present itself? What are some of the symptoms? If you are not a medic, what should you be looking out for?
So, breast cancer can present in physically in numerous ways. One can feel a lump in the breast. And so that doesn't necessarily mean it's breast cancer, but that means you should have that evaluated by your doctor with an examination or an ultrasound. You could present with bloody nipple discharge or secretory discharge from the breast that's unusual. It doesn't necessarily mean that that's breast cancer, but that could be some of the signs. Usually those are late signs of breast cancer. And so we hope that if you feel a lump within your breast, you can get that evaluated. And that can happen in a lot of young women because they're benign disorders or non-cancerous lumps that you can find in the breast. So you should have any lump evaluated so that your doctor can tell you whether it's a finding of breast cancer or something that is non-cancerous.
Are there like skin changes too that happen with breast cancer?
Yes, skin changes are late signs. And so if you have changes within the skin, such as thickening of the skin or what we call a dimpling or retraction of the skin, that is a late finding, as well as a redness to the skin can be in a very aggressive type of breast cancer called inflammatory breast cancer, where it starts in the dermis of the skin. And all of those things should be evaluated. And again, that's either an aggressive cancer or late findings of a breast cancer.
Okay, so Dr. Dede, how is breast cancer diagnosed? So we've talked about the symptoms, but how is it diagnosed?
Would you like to? Yeah.
Sure.
So if you go in to see your doctor and you have a lump within your breast, your doctor can either take that lump out of your breast, or most commonly we sample that mass with a needle, which takes a sample of the abnormality and send it to the doctor, call a pathologist to review it under the microscope to see if it's cancer or not. So that's a diagnostic finding on a mass, a sample of that mass to find out if it's cancer or not.
Okay, so once someone is diagnosed with breast cancer, kind of how are they treated? What are the treatments for breast cancer?
So the primary objectives for treatment of any cancer or breast cancer is to get rid of that cancer. And the way you get rid of the cancer is dependent on how big the cancer is, the stage, and that's where it is in your body. And so the treatment for breast cancer is based on the type of cancer it is, and it can require removal of the cancer or removal of the breast. And dependent on the type of breast cancer, you may have to have what we call chemotherapy or endocrine therapy. And depending on the type of stage that you present in, you may also have to have radiation to the breast, or if you have some type of breast preserving surgery, they would recommend radiation to the breast as well as removal of the cancer.
So let's say someone comes in and they have maybe what is an early stage. What type of treatment will they expect?
So early stage breast cancer can be defined as one in situ cancer, where the cancer is just within the ductal system. And so that early, we would look at that cancer, the size, and we would be able to take the cancer out with a procedure called a lumpectomy, and then radiation to the breast. Early stage breast cancer can also be defined as a small cancer that is invasive and has a positive estrogen receptor or progesterone receptors, where we can remove the cancer and target the cancer with lumpectomy and radiation and endocrine therapy. So those are your stage 0, that's in situ, stage 1 and 2 cancers. Those are cancers that aren't very aggressive within the breast.
Now, how about those that are late? So if we say we talked about early cancers, but late cancers, what can they expect if someone presents with that?
So again, the presentation of cancer is very important, and studying how the biological behavior of targeted therapy for late cancer. So that's your stage 3 or 4 cancer. In a stage 3 cancer, that means you have a large lump in your breast that's also spread to the under your arm. We call those the lymph nodes under your arm, or the axilla. And so if you have a large mass with enlarged lymph nodes, that could be a stage 3 cancer. And the treatment would be based on the estrogen, progesterone, or HER receptor, chemotherapy, surgery, and then surgery would most likely be removal of the breast, unless the tumor has decreased with the chemotherapy in the individual treatment stage. And it kind of depends, and Dr. Dedney, you can probably answer this question on what's available where you are in your country.
So, Dr. Dede, can you maybe talk about how we were talking about how breast cancer is treated, and she's kind of mentioned different types of surgery, hormonal therapy, chemotherapy, radiation therapy. In your part of the world, kind of what is available and how is breast cancer treated?
All right. So sorry, let me apologize for my unstable Wi-Fi. I've changed it, so I hope it's better now. You can hear better now? Yes. All right, great. Good. So we in Ghana, that's where I am, so that's what I can talk for. We pretty much have all the treatment options available, especially when you go to the big cities. So it's not everywhere in the country where you have everything available, but in the big cities, yes, you have access to breast conserving surgery, to radiotherapy, to hormonal therapy, to chemotherapy, and even to targeted therapy, immunotherapy. So based on what you present with and based on the characteristics of the tumor and all the other things we look at, patients do have access to all this treatment. I would say possibly, let's say chemotherapy, for instance, they would have access to chemo, but maybe not the full range of drugs that would be available elsewhere. Immunotherapy, the same. Some of them tend to be rather expensive. So we may not be able to have access to everything that people in other parts of the world would have access to. But baseline surgery, radiotherapy, chemotherapy, hormonal therapy, immunotherapy is available.
Dr. Dede, can I just find out, does the health insurance cover these surgeries and treatments, or do you have to pay everything?
All right. So in Ghana, the breast cancer is actually one of, I think, 2 cancers on the national health insurance. So it's a very good thing for us and for our patients. But unfortunately, it doesn't cover every aspect of the treatment. So it covers some aspects and helps to make the out-of-pocket payments a lot better. But there's still some out-of-pocket payments to be made. So for instance, radiotherapy is not covered at all. Some types of chemo drugs are covered. Some types of immunotherapy are covered. Part of the surgery is covered. Some of the hormonal therapies are covered. So all in all, it's useful, but it doesn't cover everything comprehensively.
So so we've been using kind of the terms like hormonal therapy and chemotherapy and immunotherapy. there may be some people who may not necessarily understand the difference. Can one of you kind of at least break it down and say kind of what is hormonal therapy, what is, chemotherapy or immunotherapy, and what is its role?
Yes, so chemotherapy drugs are drugs that are given that target the DNA at the DNA level where the cancer starts. And some cancers are more responsive to chemotherapeutic agents. And that's again dependent on, we look at the biological behavior. So we talked about the estrogen, we talked about hormones and the change of life from puberty through adulthood or through menopause. So you can have an estrogen and progesterones. And so you can give targeted agents that can either block that hormone for working or block the production of that hormone. And that's usually endocrine therapy.
Now, how about immunotherapy? I was saying, how about immunotherapy? What is that, and how does that work?
Dr. Denny, you want?
All right, so there are certain specific receptors, and one of them in the breast, for instance, is the HER2 receptor. So when a patient is positive for that receptor, then there are certain targeted medications, antibodies, which can be given against these particular receptors. And because it's a very targeted, and it's positive and you are aiming for that, it tends to be very specific in its action, and patients tend to respond better to those medications.
Okay, so before we move on, whilst we are still on treatment, so sometimes we hear about people having triple negative breast cancer. So what is that? I mean, when we say triple negative or triple positive, what is that, and how does that affect how they respond to treatment?
Okay, so I just mentioned the HER2 receptor as one of the receptors we look at. The other two receptors are the estrogen receptors and the progesterone receptors. So there are basically three receptors that we would want to test for when we are dealing with breast cancer. So it's either positive or it's negative. So if all three receptors are negative, then we say the person is triple negative. If all three are positive, the person is triple positive. There can be combinations of it. You can be estrogen receptor positive and negative for the other two, or negative for estrogen, progesterone, but positive for HER2. Basically, what that does is, one, it tells us about the likely behavior of the tumor or the cancer. So, for instance, we know triple negative tumors tend to be a bit aggressive. We know estrogen and progesterone receptor positive tumors tend to be a bit slow growing and less aggressive. So it gives us a general idea of the behavior of the tumor. And then secondly, also helps us in choosing our treatment options. So for instance, for somebody who is triple negative, this person will not benefit from hormonal therapy, neither will they benefit from the targeted treatment, the anti-HER2 treatment. So really what you have left is chemotherapy, and most patients with triple negative cancers would require chemotherapy. On the other hand, if the patient is HER2 positive, then you know that you need to give them the anti-HER2 treatment, which usually would go along with chemotherapy. If they are hormone positive, then as part of their treatment, they receive hormonal treatment. So basically, it guides us, it gives us an idea of how the tumor will behave, the prognosis, but also guides our treatment choices.
So knowing the behavior of a tumor is very, very important, as just talked about. And you can also give treatments that target the make your immune system work to treat that cancer through separate mechanisms, depending on that behavior of the cancer.
So
right. Go on, Prof.
So Dr. Rhonda, you talked about some of the surgeries, but can you maybe break it down? You mentioned lumpectomy, and then you use the term breast conserving therapy. Can you kind of break it down and tell us about the different surgeries? Maybe kind of what can a woman expect if you say lumpectomy versus if you say breast conserving therapy versus if you say you are removing the breast, right?
So breast conservation therapy was defined to indicate preservation of the breast plus radiation or plus or minus lymph node evaluation as needed based on that cancer. So lumpectomy is just a component of the breast conservation um, treatment. And lumpectomy is removal of the cancer with normal margins around it. And then, depending on that cancer, the lymph nodes. So we have lumpectomy, that's just taking the cancer out of the breast. If it's an invasive cancer, doing the lymph nodes and then providing radiation is considered breast conservation therapy.
Now, can you talk about the other surgeries too?
The other surgery would be mastectomy. That's removal of the breast, and that's called a simple mastectomy, depending on the cancer, with lymph node evaluation, checking the lymph node, or what we call modified radical mastectomy is removal of the breast cancer with the lower lymph nodes under your arm to treat that cancer. All of these cancers can be combined with reconstruction depending on the patient, their desires, and what's available to them.
Okay, thank you.
Brilliant. Thank you very much. I want to say hello to Muntali Faith. I believe you're watching from Zambia. Thank you for joining us. Pastor JPC, thank you for the mass tagging that you've done here. Please let know where you're watching from. And yeah, if you have any questions, please, you could inbox it or you could just type it up. And the doctors are more than happy to answer those questions. Right, so you've been talking about surgery, removal of breast. I'm just wondering, what are some of the emotional and psychological impacts of breast cancer on patients? Could you please talk us through that? Thank you.
All right. So first of all, the diagnosis of a cancer is usually quite devastating. And then the fact that it's breast, women are quite attached to their breast. It's an important part of our bodies. So the fact that it's a cancer one, secondly, the fact that it's the breast. So people tend to at times kind of feel depressed, anxious. It's a lot of psychological stress and psychological trauma having to deal with breast cancer. Beyond the diagnosis alone, the treatment as well carries its own stress. So chemotherapy, for instance, could come along with certain side effects, maybe a little difficult to go through for some people. Surgery, as you rightly mentioned, having to lose the breast. At times, even with the conservation, it still doesn't look like what it was before. You notice there is a difference. So it tends to have a bit of emotional trauma and emotional distress that goes along with it. People respond in different ways. Some are anxious, some are afraid, some are depressed. A whole host of reactions, but generally it's from a number of things: the diagnosis, the treatment, the fear of what the future holds. All that puts a lot of the patients through a lot of emotional and psychological trauma.
So, Dr. Rhonda, Dr. Dede has talked about the kind of the emotional and psychological impact. How about the cosmetic impact? How do we address those? And then sometimes when the women get chemotherapy, they lose their hair. I mean, they become bald. So all those things, how do we address kind of some of those challenges?
Dr. Dede talked about breast conservation therapy. And one of the things, once you operate on the breast, the outcomes may not be the same as you're expecting. You have to discuss the surgical changes in the breast. And then if you receive radiation, the radiation changes to the entire chest wall can be very disturbing to a patient. And sometimes these side effects from the surgical treatment of preserving the breast can not be good. So we've taken into account and we try to address those by offering different types of surgical procedures that leads towards symmetry, or reconstruction of that breast, or if you have a mastectomy of that chest wall with implant-based or using your own tissue for reconstruction. So there are many options to try to address that. But as we say, there's nothing that's going to give you that full natural preservation of the breast, or without changes to the breast that can be very stressful to women.
So maybe as a follow-up, Dr. Dede, maybe you can talk about this. So I know in the US, sometimes we have special bras for women who have lost one breast, so that they can stuff it up on the side where they've lost their breast. Do you have access to those, or do you have those for your patients? And then also when the women have lost their hair, kind of what are some of the things that they can use? Just wearing wigs, or are there other things they can use?
All right. So for the bras, some people have it, but I wouldn't say it's very readily available. I mean, we know these days we live in a global village, so really everything is available to anybody depending on the means you have. So some people are able to get it. We have a few NGOs and support groups who would come in and bring such things from time to time, but it's not very commonly available. So what the women tend to do is just to continue to use their old bras and to put some form of external prosthesis in there. For the hair loss, I think these days wearing wigs is very much in vogue. It's something that almost every woman would have tried at one point or the other. So usually what we tell them to do is to start, especially if you are not too used to wearing wigs, to probably start before you lose the hair. So that is not a very drastic change. Suddenly you are not wearing wigs and then you suddenly start. So for those who wear it all the time, or wear it often, it's not much of a big deal. But for those who don't, we encourage them to at least try it on a few times before they get to the point where the hair all falls out. So that is useful, that helps. Some actually are not very bothered and are okay just walking around like that. So it's very much an individual thing. It depends on the person. I think I just wanted to add a bit about, still on the psychological effects, how we try and deal with that. So a lot of counseling goes into that. I think getting the patients to understand the nature of the disease and the need for therapy, because when they don't, then they may decide the side effects are really not worth having to go through, having to lose all my hair. It's really not worth it. Let me just live with this disease. But when they understand the need for the therapy, it helps making the choices a little easier. And then, of course, we offer them various treatment options. So Rhonda talked about reconstruction. We find in Ghana that for some people who are very averse to mastectomy, when you talk about reconstruction, they actually reconsider. At times, they may not even go through to have it, but just because they've been able to meet with a plastic surgeon, they've had that conversation, they feel more comfortable to go ahead, knowing that at any point they could go back to have reconstruction. And then we have clinical psychologists we work with as well to support. We found survivors to be a very important source of support. So at our clinics, for instance, we have survivors come in every week, and at times they show the patients their scars, and it makes the patients appreciate a bit more what the whole thing is about and what they are going to go through. And then the support of family and friends, also very important. So all this helps to be able to get the patients to cope. It's a lot to go through, but I mean, it's definitely not impossible. Many people have been through it, and with the right support, others are able to go through.
Thank you. Let me just say hello to Sama from Gambia. Say hello to the boys for me. Thanks for joining. Thanks for your participation. And we have a question here from Amy from Ghana. Thank you for joining, Amy. He says, could you please explain what can be done to a swollen armpit lymph node about 1.2 per mammogram outcome? It's not cancerous. So,
So Yes, I assume you are saying somebody has taken a mammogram for whatever reason, maybe just screening, maybe for some symptoms, and lymph node enlargement has been found, but the mammogram says it's not cancerous. So women especially could have lymph node enlargements that are not cancerous. It's not every lymph node that is enlarged that is as a result of a cancer. When we feel the lymph nodes, at times we are able to get a fair idea, depending on the way it feels, whether this is likely to be cancerous or not. And even better still, the imaging gives us more information. So very often when the imaging says that it does not look cancerous, then we are almost certain that it is not cancerous. And if there's nothing else that is making us suspect a cancer, then we put that in context and we just keep an eye on it. It's not anything we are worried about. But if for some reason we think that there could be a cancer, then we may want to go ahead and do further tests, maybe a biopsy, take a bit of it and send it to the lab. But very often, if there's nothing in terms of symptom-wise, nothing that the imaging has picked up, and it's just the lymph nodes and they look benign, then we just leave it alone.
Okay, so Dr. Rhonda, how do you address that separately? I know you use ultrasound in the clinic and you may biopsy things, when you see the patient. Can you talk about kind of, in this particular example, how you would approach it?
So most of the times when a patient or individual has gotten a mammogram and they found a lymph node, the radiologist will look at that lymph node and they have characteristics of that lymph node that they'll evaluate. We typically will look with ultrasound and morphologically on ultrasound, and ultrasound works by sound waves and it gives you an image of the abnormality. And based on that, you can look at that and see if morphologically it looks abnormal by different characteristics of it. And as Dr. Detney said, you could get a sample of it and send it to the lab if it looks abnormal. If it doesn't look abnormal, actually enlarged lymph nodes can occur for many reasons under the arm. The most common thing is if women shave or men shave under the arms pit with a razor, they can get enlarged nodes, or infections can cause enlarged nodes. Most of the time, it's not cancerous.
Thank you, Dr. Rhonda. I want to say hello to Sister Nakoa. Thank you for joining. And I hope I haven't missed anyone else. But yeah, please keep telling us where you're watching from and keep sharing with friends and family. Right, so my question is, Dr. Dede, so other than losing the breast, losing the hair, what are other side effects of chemotherapy?
All right, so some of the other common effects of chemotherapy are nausea and vomiting, feeling a bit tired, anorexia, at times a bit of mouth
Dr. Dede,
sores.
could I just ask you to use everyday English so that my 7-year-old...
I'm sorry, I thought I was using everyday English.
So you said anorexia. Sorry. What is anorexia? So that we all know what you're talking about.
I'm very sorry. So, I mean, not feeling like eating, you don't want to eat anything. And a lot of times it's related to the nausea and the vomiting. You smell the food and you feel like throwing up. So you don't even want to, the appetite to eat is not there. So basically loss of appetite. And then feeling tired, at times some mouth sores, at times a bit of diarrhea because the lining of the intestine can get inflamed. So you can get a bit of diarrhea. And then there's also, now I'm trying to choose my words carefully, bone marrow suppression. So within our bones, we have what we call the bone marrow, which forms the blood cells. And there are three main types of blood cells: the red blood cells, and then the white blood cells, which deal with infections, fight infections, and then the platelets, which try and prevent bleeding. So chemotherapy can suppress all these, and then the effect is that the patient could become anemic. Sorry, I think I went off a bit. Yeah, so the patient's blood levels could go down, Patients could be prone to getting infections, and that's at times it's a little worrying. So we tend to look out for it and handle it quickly if it occurs. We always would ask for blood counts before we do chemotherapy and in between chemotherapy, so that we try and prevent, or maybe I shouldn't say prevent, but we try and catch some of these complications early and prevent any further problems. And then if it's the platelets that are affected, then they are prone to bleeding. So these are all possible side effects. Some of the particular drugs will also have particular effects on specific organs. So some, for instance, could affect the heart. And so because of that, we always would assess the patient well, see whether there are any, especially if it's a drug that could do that, see whether there are any risk factors already for that. And there are times we would want to actually avoid particular medications because of the patient's state already. Some can affect the nerves. Some can cause changes in the skin, darkening of the palms, the nails. Some can affect the menses. So especially when you have a young person or somebody who is interested in having more children, then that's always a conversation that you need to have, because especially if they are a bit close to menopause, then the chemotherapy could induce menopause. So you need to discuss with the patient their fertility wishes, whether they want to have more children or any children if they don't, and then try and put in the necessary measures to see what you can do to preserve that. So generally, when it comes to the side effects, we try and prevent the ones we can. So the vomiting, for instance, we usually would give anti-vomiting medications to try and reduce that. So what we can prevent, we prevent. What we can't prevent, we try and pick up early so that it doesn't become more serious.
So thank you for that. I think, the other questions we've kind of answered, in terms of hormonal therapy and all that. But since you are on chemotherapy, so let's assume that you have somebody who is pregnant, okay, and then they find out that they have breast cancer. How is their treatment different than someone who's not pregnant? And maybe either of you can address this.
Yeah, breast cancer in pregnancy is treated depending on where the woman is in her trimester. And so early, mid or late trimester, if you're past the second, I guess you would say trimester by months, 21 months, that's considered second trimester. And so if you're past that and the baby is doing well, you continue treatment as based on the disease. If you're early in your pregnancy, 4 to 6 weeks, and you don't know, then of course, you have to talk about the side effects of the medication and the possibility of losing the baby. And so, but in general, we treat women with breast that are pregnant with breast cancer according to where they are in that the baby and how the baby's doing. So treatment is not stopped because of a pregnancy.
And probably I'll just add that probably certain medications are avoided.
Yes.
But generally, there's still a number of chemotherapeutic agents that are safe in pregnancy. So for the few we know are not safe, it will not be given. But there are quite a number that are safe that can be given. And it's also radiotherapy, definitely it's a no-go for during pregnancy. So if you need that, then possibly after you've delivered, depending on how the timing goes. Rhonda mentioned the timing. When it comes to the delivery as well, we need to consider that. So you don't want to give a woman chemotherapy and then next week she's delivering. That could be a problem. So it's always, we work very closely with the obstetricians when we get pregnant women with breast cancer. So the oncologists, obstetricians, and then we time everything just to make sure mother and baby are both safe.
Could I just ask, out of interest, could the mother still breastfeed her baby, or does it depend on the stage of the cancer?
So it really depends on the treatment that she has. But yes, she can still, if she still has her breast and is making milk, she still can breastfeed her baby.
Fantastic, thank you. Oh, I want to say hello to Eric Kweku. Eric, I'm not sure whether you are Pastor George's brother, but yeah, thanks for joining. And he's sending shouts out to you, Prof.
Yes. Yeah, so that's me. um, okay, so we'll continue. So, I know we've talked about hormonal therapy, targeted therapy, and radiation therapy. I think I'm just going to add all three. So we've talked about side effects of chemotherapy kind of in detail. Maybe Dr. Rhonda, can you just summarize what the side effects of these, like hormonal, therapy or targeted therapy and radiation?
So let's just start with radiation first. The biggest side effects from radiation, as Dr. Debney mentioned, you can be tired. It can cause a lot of tiredness, and it can cause changes to the skin. And we like to say that radiation is a gift that keeps on giving, because the reason for the radiation is to protect the breast throughout your life so that the cancer doesn't grow back. And so your skin can be thickened, your skin can be darkened, and depending on your pigmentation in your skin, if you're color, you have more melanin, it could be darker. If you're less melanin, you can have a redder skin and thickening. And then over the lifespan of your survival, your breast can shrink or retract over time. So the breast can be smaller than the opposite side, but it does prevent recurrence within the breast. Hormonal therapy, that's the therapy where we block your estrogen from working on the receptors, or we block your body from producing estrogen, is similar to going through the change of life. Those effects from not having estrogens. So weight gain, you can also have darkening or pigmentation of your skin in certain areas. You can be fatigued, tired. You can have mood swings. We talked about the psychological stress of breast cancer. Estrogen is good. It makes you feel better. Decreased wanting to have sexual function with your partner. And I think that's so important that it's discussed with individuals, because the treatment of breast cancer involves your partner as well, because they have to know about the changes you're going to be going through. And not having estrogen, you can talk to your doctor, because vaginal dryness is a very common complaint. And we have medications that can help with all of these symptoms if you're experiencing those, because we talked about hormones causing breast cancer. To block those hormones can cause the things that cause symptoms as well. So we want to look at things that we can do to make you have a better survival as you're treated for breast cancer. All the treatment, you should try to address the problems and the side effects from the treatment.
Right, thank you. Dr. Dede, just a question on top of my head. You've been talking about the psychological and emotional effects or impact on the patient. Now, how do the partners take it, especially in Ghana?
I guess we see a whole range of them. You get people who would come in religiously with their partners all the time, and the partners are very supportive. They also go through a lot of the trauma. I mean, if you are living with somebody who is your partner, the two are supposed to be one. So whatever one is going through, the other is basically going through the same or maybe even worse. So for some partners, yes, we see that they are also very traumatized. But then they are there to support the patient. Some are so traumatized, they just shut down, and you don't even see them. And the patients complain, they go home and they wouldn't even talk to them about it. They would even ask how the hospital visits went. And it's just because they are not coping well. So we have the extremes. Those who, I mean, I guess it's difficult for everybody, but there are those who try and support the partners through. And on the other extreme, there are those who just can't cope themselves and can't offer any support to their partners, unfortunately.
Right, thank you very much. Dr. Rhonda, so the next question comes to you then. So is breast cancer curable?
So the goal is treatment is for cure or remission of the disease, but we have to always remember that we keep the patients and follow up because breast cancer can recur. And so all the treatment is designed to get rid of the disease. I cannot just say that we have a cure for breast cancer, but we are able to put patients in a state where they don't have symptoms or signs or notable disease.
So, so you mentioned that breast cancer can recur. That means that after it's treated, it can come back. What are the chances of that happening? Let's say somebody, develops breast cancer, they're treated and they are in remission, and then later on it comes back. What are the chances that will happen? What's the likelihood of that?
So that varies based on the stage of where they are when they come in for their cancer. So, and the type of treatment that you have. And so we've talked today about people finishing treatment and getting the right treatment. So if an individual comes in with an early cancer, as we talked about, that's where the cancer is small, hasn't spread outside of the breast, and they undergo breast conservation therapy, that's lumpectomy with radiation, and we know if they could take hormonal therapy and they take it, then their chance of it coming back is very small. Sometimes, if you look at a number, their chance is only about 10% that cancer will come back. And so they do very well. But if an individual comes in and the cancer is at a stage 3 or 4, then their chance of it coming back is much higher. But then you have to take into account the treatment they receive. So if they don't receive any treatment, of course, the cancer will continue to grow. But with all of the treatments, with surgery and chemo, and depending on the type of cancer, whether they have endocrine blockage or not, then they will have a greater chance that it won't come back. But the greater the stage, and we quote numbers to the patients of if it's a 50% chance that it'll come back, that the treatment will reduce it by half of not coming back.
So, we've talked about the side effects of all the different treatments. Now, are there any long-term side effects? I mean, that is, I think most of the things we talked about are related to whilst they are receiving the treatment. But are there any long-term side effects that linger on after they've been, treated?
So, yes, there are, and Dr. Dedney talked about the side effects. And so one of the ones that I see, and you can talk about the side effects from surgery, the side effects from the radiation, the side effects from the chemo or endocrine therapy. They all can be long time. I mentioned the radiation therapy with radiation that over time the breast can shrink and continue to have changes within the breast. The blockage of the estrogen puts you into side effects like menopause. And we talked about those, and those are long-term effects unless you get some treatment to support that. That some of the chemotherapeutic drugs can cause neuropathy or numbness and tingling within the fingers and toes. And depending on the drugs or medications they receive and how bad it initially is, and or if they get treatment, will determine how they respond to that. And so all of the treatment can cause some long-term effects, but then most women do very well with support if they can get support with it.
So I'll follow it up with a question for both of you. So sometimes after treating breast cancer, women will develop swelling of the arm, what we call lymphedema. How common is that, and how do you manage that?
All right. So I think the risk of developing lymphedema, it could actually come from the cancer itself. So where we see very advanced cancers, at times even before treatment, the patients already have lymphedema because the cancer It's in the lymph nodes and blocking the lymph nodes. So there's accumulation of fluid in the upper limb. But beyond that, once we do surgery, especially if the lymph nodes are involved, we need to take them out. And once we take it out again, we disrupt the flow of excess fluid from the limb. So that could result in that swelling. Radiotherapy as well, that's the same. It causes a bit of fibrosis in the long term, and that would also disrupt the flow. So the cancer itself, as well as its side effects. So if you come with an early cancer, then usually if lymphedema occurs, it's more often from the effects of the surgery and radiotherapy. And the important thing is to be able to pick it early, because when it's picked early, it's a lot easier to take care of it. Some physiotherapy, wearing some compression stockings, doing some exercises. So usually when we see it, we would send the patients to the physiotherapist, and they help to manage that, and it tends to keep it at bay. How common is it? It doesn't happen to everybody, and at times it's a bit difficult to predict who will get it and who will not. So I don't know the figures. I don't have figures off the top of my head. I don't know whether Rhonda has any figures, but it's not everyone who gets it. So,
and just like
definitely less than 50%.
Yeah, just like it depends on the presentation of disease and the surgery and radiation you have. In the U.S., they've studied some of the types of ways that you can avoid it. There's surgical procedures that they reanastomose the lymphatics back together, and then they do procedures to preserve the lymphatics, like the axillary reverse mapping technique, where they'll go in and identify the lymph nodes that serve the arm to prevent you from taking those. But if they involve cancer, you still have to take them. And the more you do, I always say the more you do, the more risk of you getting lymphedema. And the numbers range from, if you have a lot, like node dissection, radiation, and mastectomy, can be as high as 15 to 20%. And depending on if you have a sentinel lymph node where you just sample the axillary nodes, it can be as low as 6%. And not only do you get decrease the swelling, but the numbness in the arms that you can have from removing the nerves that supply sensation to the arm, mostly the back of the arm.
Right, let's go to some more good news, I think. Prevention. Can breast cancer be prevented at all? And if so, what do we have to be doing now?
So prevention is very important, and prevention starts with you. I always say it starts with ourselves. One, diet, exercise, knowing your family history can help you. Screening doesn't prevent breast cancer, but it definitely provides early detection that can change outcomes from breast cancer. So we talk about alcohol, and so alcohol is not good for anything. So even one drink of wine a day can increase your risk for the development of breast cancer. And all of this, again, is back to that big circle of estrogen relationships with diet, exercise, and they say you can reduce your risk of breast cancer with a healthy weight and a healthy exercise program by 25%.
Oh, really?
Yes.
Right.
And, even so, I always tell women that, and men, a healthy diet and an exercise program can change the health outcomes for many things.
That's really good. So I like what you said, that alcohol doesn't help with anything. And I like this bit about just healthy diet and a bit of exercise can change the outcome of anything as well. Yes. So that's really good. Right. Lovely. Thank you.
So just to add a bit.
Go
Sorry,
on.
I wanted to add a bit to the prevention. Yes. So for those who have the genetic defects, they may want to be a little more drastic. So there's the option to actually go in and have both breasts taken out. We call that a prophylactic mastectomy. So there's no cancer there, but because you know you are at risk, once you take out the breast tissue, the chances of you getting breast cancer is reduced significantly. So that is one way for those who have the proven genetic defects to try and prevent it. There are times we get women who are coming in for treatment of breast cancer on one side, and they opt to have the other breast also taken off, although there's no cancer there. So again, it's a preventive measure to try and prevent development of breast cancer on that side. And then the hormonal treatment that we use for the breast cancer can also be used as prophylaxis. And again, it's usually for those who have a proven high risk, because all the medications have their own side effects. So we wouldn't want to just put everybody on it because it could prevent breast cancer. But when the risk is very high, then there's the option to use that as well.
So I think talking about the prophylactic mastectomy, where, you know, somebody who has the genetic mutation. So Dr. Rhonda at the beginning mentioned the BRCA mutation. I think there is a popular person who had her breast removed, Angelina Jolie, you know, who has the BRCA mutation, and so she went and got both breasts removed prophylactically, so that she, because her risk of developing breast cancer is very high because of that mutation. So then she went and got both breasts removed, and I think that's fairly common in this part of the world. Dr. Rhonda, how often do you have women come to you for that?
We have women, we have what we call a high risk clinic, and we have we do genetic counseling and testing on patients based on risk. And so if they have a genetic mutation, it's very common that they will have either prophylactic oophorectomy or removal of the ovaries and removal of the breast, because depending on where you are in your lifespan, a woman may choose to remove the breast, remove the ovaries, or whatever risk factors they are. But you can, by removing the ovaries, you reduce the risk to the breast by about 35%, they say. And so if you look at, and you talked about Angelina Jolie, her history was very interesting because her mother had ovarian cancer, died of ovarian cancer, and tested positive for the BRCA mutation. And Angelina Jolie was still within her childbearing age, so she had the prophylactic mastectomies and had children, continued to have children. She was young. And so you have to take into account people's stages of their life and where they are when you look at those genetic mutations, because genetic mutation is not just one organ, it's a syndrome of cancers, and it could be associated with the breast or with the colon or with the stomach, with the thyroid, and with leukemia. So you have to know what your mutation is. It's like I said, numerous mutations now that we've identified that shows an increased risk for breast cancer and other syndromes.
Thank you, Dr. Rhonda. I want to say hello to Erica from Nigeria, Afolabi, thank you for joining from Nigeria, and Isaac Mutai from Kenya. Thank you for joining. Keep sharing with your friends and family, and it will do them a whole lot of good. Right, Dr. Florence, so my question is, why is it that people tend to come in when it's a little bit too late?
Sorry, please, can you repeat the question?
Why is it that when people see, when they begin to, or when they first detect that, oh, actually, there seem to be an enlargement, or there seem to be a lump in the breast, why is it that they are always hesitant in seeking medical help straight away?
All right, so the line seems to be breaking a bit, but I guess you're asking about the late presentations, why people are hesitant to seek treatment.
Yeah.
And it really is a complicated thing. There are a lot of factors that account for that. Unfortunately, in our part of the world, we see a lot of late presentations. So quite a few studies have been done. And some of the factors that we've come up with are the fact that, one, people don't seem to understand the disease. There's a lot of misunderstanding. There's a lot of misinformation, a lot of myths and misconceptions. So once they don't have the right facts about the disease, then or about the cancer, they tend to take wrong decisions when it comes to it. So one, for instance, very common in our part of the world is that it's caused by, it has a spiritual cause. And once you believe that something has a spiritual cause, then really what's the point of going to hospital? You need to go either to the church or to the prayer house, and that is where the problem can be solved. So we tend to spiritualize a lot of things, and unfortunately that keeps people from coming to hospital early. They notice the symptoms and they misinterpret the symptoms. So a very common thing that's said in our environment is that when you have you're breastfeeding and you have the baby belching onto the breast, then it makes your breast swollen. So somebody who is lactating notices a swelling of the breast, which could very well be a cancer, but because there's this notion or this explanation to what they are seeing, they wouldn't come. Again, in our part of the world, it's said that if you have a boil, you shouldn't touch it with a knife. So once the patient sees some swelling, some lump, some obvious swelling over there, they interpret that to be a boil. And obviously they don't want to come to hospital because they know that in hospital it will be cut with a knife. So there's also the fear, and the fear again is multi-dimensional. There's the fear of the cancer, there's the fear of the impact of the treatment, there's the fear of the outcomes, there's the fear of stigma, there's fear of the cost implications. So there are so many things that weave their way into why the patients don't come. There is the cost implication as well. So as much as some people actually just think that, oh, this is so expensive, I wouldn't go. They don't even know how much it is. For others, they do come and genuinely they cannot afford the treatment. Access to treatment. So I mentioned earlier in the big cities, if you are living 500 kilometers from Accra and you have to come, unfortunately in Ghana, we have radiation facilities or radiotherapy facilities in just 2 towns or 2 cities, Accra and Kumasi. So if you live in the northern part of the country, for instance, you have to come all the way down to the south to be able to, at least to the mid region, to be able to get access to that. So getting access to treatment, it's also an issue. We tend to like a lot of alternative medicine and partly or alternative treatments, partly because of our spiritual beliefs, but we tend to try a lot of alternate medicines as well. There's all these myths and misconceptions about chemotherapy and radiotherapy being poisonous and killing of normal cells. So people would rather avoid that and go for something that may not work so well. So all these things add up, and some patients either would not come early at all. Some studies have shown that people notice changes and sit at home for a year or even more before they come to hospital. On the other hand, some would come early and even have a diagnosis made, but because they don't like the treatment that is offered, the mastectomy that has been offered, or the chemotherapy, or at times they would even start, they'll do one form of treatment and then they disappear, they don't continue. So all that doesn't end up giving us very good results.
I always say that breast cancer is one of the diseases that we have studied for so many centuries, and I think about learning about breast cancer and some of the things that Dr. Florence was saying. It's because we know so much about how to treat breast cancers through so many women who participated in clinical trials that led us to know how to treat breast cancer and what works and doesn't work. And so all of those things are just so important. It's one of the most studied cancers across the world. And so if anyone's listening, they've had the opportunity to support and be a part of a clinical trial, or someone asks them to be a part of a clinical trial because of their cancer, then it's really important that we continue to learn what we can, not just about drugs and treatment, but about emotional and spiritual misperceptions that we hear, because we want to change that individual's mind that this is the way. And so having symposiums like this is so important. And I thank you all for that.
Thank you, Dr. Rhonda. Thank you very much for that. And thank you, Dr. Rhonda and Dr. Dade, for their time. I think having such webinars is really important. So thank you for offering to do this for us today. But I have a question for you, Dr. Rhonda. I don't want to believe that misconceptions and myths are only common in Africa, are they?
Yeah, they're everywhere, unfortunately. And
Tell me some of the misconceptions and myths you've come across.
yeah, we experience some of the same things in the U.S. and people believe what they believe and what they study and who they trust. And so this being a part of the wisdom conference and for you to provide this to the individuals and what they believe and I believe in trust in God and everything and spiritual wise because he is our leader and but there are so many things that we know that I always tell patients that I am who I am because of where God put me to learn the science and to help others. And the same thing about those who teach me about the words of God in the Bible. They can teach me those things so that I can pray and help patients along the way with the spiritual word and wisdom as well. There's so many factors that come into play when you care for a patient with any disease, but specifically cancer. And prayer does change things, as well.
So, Dr. Rhonda, in the US, do you tend to see these misconceptions more so in African Americans than in the white population?
No, I don't. I see it in it's really health education and literacy and their understanding is really important factor and what people have seen and how they interpret that. So no one is going to believe that mom went to the hospital and because they had surgery, the cancer spread. When the exact factor is that when they went to the hospital, the cancer was already spread, and that there wasn't a lot that the doctors could do to change the outcomes. And no one discusses that with the family when they go back home. That yes, the cancer's there. The doctor did say that it's spread, but they could try this, but it didn't help. And so the more advanced a cancer is in any situation, the poorer the outcomes. And so we have to continue with the education of how we manage our health overall. And so I always like to talk from that perspective of how you manage your health overall. And so those who exercise and eat right, those who go in to get things that are abnormal checked, it's very important. And those are the ones that will survive those things that are advanced. And so advanced disease, whether it's losing a kidney from hypertension, untreated hypertension, or fungating breast cancer that spread and they die, is not from not getting treatment.
So I think that's a very important point, and I want us to harp on that again. And Dr. Dede kind of mentioned it a little bit when she was talking about the myths and misconceptions. I think, especially in Africa, when some people believe that, oh, you have breast cancer, if you go to the hospital and they cut on it, you're going to die. And it's because they are coming in late already, and sometimes the goal of the surgery is just to remove a very large, smelly thing, just to give the woman some quality of life, not necessarily to cure because it's already spread. And so then they die shortly after that surgery, and then people think that it's related to the fact that if you cut on breast cancer, they are going to die, and then they don't come. Can you address that, Doctor? Can you address that a little bit? I'm sure you see that often.
Yeah. So, I mean, what we try and do these days is we try and make the patients very much aware of what the goals of treatment are, because if like you said, we are doing what we call a toilet mastectomy, where you're not going to cure the patient, but you need to take off the breast, either because it's so huge, it's very infected, you can't control that, it's bleeding, you can't use any other means. Once the patient is having surgery, in their minds or in the minds of the family, that is to cure the patient. So if you don't talk about it, then they go away with that idea. And if things don't go well, then they blame it on the surgery. So honestly, we really don't like to do the toilet mastectomies because we think it fuels that misconception. you know that what you are doing is not curative. You tell the patient, but I'm sure you know that Ghanaians are very secretive when it comes to their health. They don't share anything. There are people whose mothers have breast cancer. A year, 2 years, nobody in the family knows. How much less aunties and grandmothers and aunties, cousins, other people in the family. So it's something I think we need to work on. We need to let people know. After all, if you are in a family and something like that happens, it's like we've said, there could be genetic links. So it's important to let other members of the family know that they are also at risk so they can look out for it. But unfortunately, we don't do that. So all they know is that, oh, this person came to hospital and after surgery, the person died. Probably this thing has been going on for 2-3 years and nobody knows about it. So we're trying to, we still try and talk to the patients, talk to relatives who are available so they know what the goals of treatment are, and encouraging people to, let others know what is happening so that we don't fuel all those misconceptions that are going on. And then the more we educate, I think that also helps. Like you said, it said that if you cut it, the person is going to die. There was once I actually had a patient who was refusing mastectomy, and in probing further, I got to know that she had been told there's some form of string that connects her heart to her breast. So once you cut the breast off, it means you're affecting the heart and she's going to go. And it's very common. Most people will say within 2 years, you cut off your breast, you are going. I think another thing that doesn't help us is till fairly recently, we've been doing x-rays and ultrasounds for metastatic, well, to see whether the disease has spread or not. And at times that may not be very good in picking up the spread. So you do that, it looks like it hasn't spread, you go ahead and treat like it hasn't spread, and in a short while it shows up that it has spread. So these days we try to do more of at least the CT scans, which will give us better information so that we can stage correctly. And once you know you're able to stage correctly, then you can offer the right form of treatment. So I guess a lot is going into trying to improve things, but the education is very important. Once we educate people and they get to understand the condition better, then they make better choices and hopefully we'll end up with better outcomes.
And based on clinical trials, we know that stage 4 disease, there's no cure for it. And so even if they respond to treatment, a lot of times we won't do mastectomies or any surgical treatment on them because we know that it won't change the outcomes. And the goal is not just to remove the woman's breasts if it's not going to change the outcome. So when we're doing that, and like you said, it's to stop some, so they'll have a better quality of life, because the cancers can smell very, very bad and malodorous, and that can make people not come around you or be around your family members as well.
So as we come towards the end, so we've been talking about women because, usually when we talk about breast, we look at women, but men also have breast. And so what about men? Do they get breast cancer? And if they do, how is that treated and how is that different from how women are treated? Dr. Rhonda?
Yes, so men can get breast cancer. We say 1 in 100 men can get breast cancer, and is usually most commonly associated with a genetic mutation if they have one. But if a man gets a lump, just as if a woman presents with a lump, they should have it evaluated so that it can be sampled and sent to the laboratory for evaluation. And we treat it the same way as we do with women. So men has breast tissue, and they have exposure to hormone, and they have genetic risk. They get one gene from their mother and father. So depending on the cause of the breast cancer, we treat it according to the cause as in women. So mastectomy, lumpectomy, chemotherapy, radiation, depending on that behavior of the tumor.
So, we know that men in general don't, even though they have kind of estrogen and stuff, we talk about testosterone mainly. So in men with breast cancer, do we look at the hormonal status like estrogen, progesterone, like we look at in women? And if they do we put them on the same types of hormonal treatments?
Yes. And we also tell them not to take a lot. Today, just like with women, everybody wants to stay young and very functional, and so they take a lot of testosterone and additional supplements, as we all do. And so we have to make sure that we talk about what they're taking, diet, lifestyle, as we do with women with breast cancer.
So with men, if a man has breast cancer, is the outcome similar to women? I mean, just based on stage, or do they have a worse outcome?
It's similar, just as women. It's based on the biological behavior of that disease and when they present for care of that disease. But most men, they don't think it's breast cancer. A lot of women don't think it's breast cancer. And so they have the same beliefs and fear, as a woman. If you feel a lump in your breast, you're hoping it's nothing and you hope it's going to go away. But if it doesn't go away, I always ask everyone to have it checked out.
So, Dr. Rhonda, other than the lump, what other things should you be looking out for? So let's say you don't have a family history and there's no lump. Is there any other thing you need to be looking out for?
So swelling in the breast, bloody nipple discharge, thickening of the skin. Sometimes breast cancer is not usually painful, but you can have some focal tenderness, and that will maybe make you want to get evaluated with a mammogram or evaluation. Or if if you look at your history and you see many family members with breast cancer, then you should really get checked out. We talk about the age at which you get detected. Men don't get screened. So they're going to present with symptoms. So they're not going to, at least women can get a screening mammogram, age appropriate, risk appropriate screening mammography. Men are never in that situation where they're going to go get a mammogram in a screening program unless they have a hereditary mutation where they can get a MRI or follow up in a high risk screening. So for men, if you do feel a lump or that you have a genetic mutation, you should be seen as well and discussed for risk reduction in those situations.
So our time is kind of coming up, but let me ask this question. So you mentioned screening with mammogram, and we know that in most of Africa, they don't have access to screening facilities, maybe in the big cities and towns. So, Dr. Dede, for example, in Ghana, how do you advise women? Do you kind of tell them to do self-exam? I mean, kind of what can women do to improve their chances that they can find a lump early enough to have it taken care of before it becomes that big cancer that will take them away?
Yeah, so for those who are in the big cities, Accra, Kumasi, other cities where mammogram is available, we do advise that although there's no national screening program, from the age of 40, they could take advantage and have the mammograms done regularly. When we get people coming into the hospital, we talk to them to talk to their relatives because of the risk to also get that done. But we tend to also emphasize a lot still on the self-breast examination. So I know when it comes to the guidelines in the US, it's not supposed to be very useful or recommended. But we are looking at a situation where most of our cancers are picked up when they are quite large. There was a study done a few years ago, and I think 80% of the cancers were actually, was it 60 to 80% were more than 5 centimeters. So if you are getting so many of large cancers, then we believe that if we encouraged women to do the self-breast examination, we would be able to move down from showing up at a stage where it's 5 centimeters to probably picking it up when it's 2 cm or even 1 cm. So we do advocate for self-breast examination, regular self-breast examination, and also clinical breast examinations. Together with that is the education, because we talked about late presentation. So the whole problem is not the fact that they are not picking up the lump early. Somebody may pick up a lump at 1 cm, but sit at home for 1 year, and by the time they come to hospital, it's 10 cm. So yes, examining the breast, trying to pick up early, but the education also going hand in hand with that so that they know the right things to do when they pick up anything.
Yes, that's so important. We have some programs in Kinshasa and Zambia where they're doing the women when they come in and they're getting their pap smears, that they're getting breast ultrasounds, if they have symptoms, and they look at the breast for early detection because of you mentioned earlier, Dr. Danny, that more women present at 40s than at 60s in Africa. And so they're combining ultrasound examination of those women if they have symptoms when they're getting their pap smears and HPV vaccinations.
I think that's really good. I mean, if you go in for a pap smear and then you manage to do that as well, that's fantastic. Right, brilliant. Thank you very much. Ghanaians, it looks like tonight Nigerians won, because by far I can see that so many more Nigerians joined and viewed this program than Ghanaians, unless of course you are not commenting, unless of course you're not telling us where you're watching from. But I want to say hello to Halima Adim. Thank you for joining us from Nigeria. God bless you. And yeah, keep sharing. So just before we end, Professor Lai, you know I always have a question for you. So my question tonight is, how would you say, or what would you say to the partner who is supporting a wife or a husband who has breast cancer? How can they support? Could you just give them some practical things, maybe 3 things that they could practically do?
So I think it's important to understand that, when your wife or your husband has, cancer, this is a life-altering disease, and it's going to affect the entire family, because most of the time, and as we talk about breast cancer, 99% of it is going to be women, right? And the women tend to be the kind of the breadwinners of the family, if you want to put it that way. I mean, they are the ones that are taking care of the kids. They are the ones that are taking care of the home. And so for a woman to go through that type of treatment, as we've talked about, that may affect a lot of the woman's, emotional status, physical status, cosmetic appearance. We talked about tiredness and all those things. That is important for the man or the rest of the family to be supportive, and really pick up the pieces and help. So first of all, there's the emotional and psychological trauma or stress that the woman will be going through that she needs support with. But then also, she cannot be going through all this and then the family still expecting her, to do everything that she's been doing for the family, all that, before the cancer diagnosis. So I think that's important. And I think it's also important for the partners to come with either the man or the woman to their doctor's appointments and to get educated. As we've talked about, some of these women with cancer may have genetic mutations. And if they do, that means that your children, may be at high risk of developing breast cancer even when they are younger. And so it's important to be educated, to understand what is going on, so that, for example, if the woman has the BRCA mutation that we've talked about, which predisposes women to not just breast cancer, but other cancers, then the children will need to be tested so that they can be followed up, appropriately based on whether they have the mutation or not. So those are important things. And then the last thing I would say is that, having breast cancer should not be seen as something that should be stigmatized. Okay, having breast cancer is no fault of yours. It doesn't mean that you did something wrong. cancer, as we've talked about, there are over 2 million women every year who are diagnosed with breast cancer worldwide. And so if someone has breast cancer, it's not because of something they've done. It's not because of some old witch in the village who is doing something, to them. And I think once we understand that, we will at least destigmatize it, number one. And number two, as we were talking about before, it will help with the education because Dr. Dede mentioned the fact that, there may be a mother who has breast cancer gone through treatment for 2 years and the family does not even know about it, right? But it brings about the education. Everybody knows about it. Everybody knows what to look out for. And then it helps the rest of the community when they see changes in their breast or they feel lumps that, they will rush to get it checked out. So I think these are important points for us to understand.
Lovely. Thank you very much. Dr. Rhonda, could you please give us a takeaway, a message to take home, like at least just what out of all that you've said, what is the key message you would want us to take home today?
Thank you for having me on your program tonight. And, early detection changes outcomes and it changes lives, and appropriate treatment changes outcomes in life. So, fear is fear itself. And so we have to trust in our spirit and everything. But if you have something that needs to be checked out, you should have it done.
Thank you. So if you have something that needs to be checked out, just go and check it out. Thank you. Yeah. And Dr. Dede, what would you like us to take home today? Thank you.
Oh, you're muted.
Sorry, I was saying thanks for the opportunity, and I was also thinking about ending on the note of early detection. It can't be overemphasized. It's the best way of handling the disease. So of handling breast cancer. Once you pick it early, you go through the treatment, the chances are so much better. And it gives you confidence knowing that the possibility of it even coming back is so low. So let's not be afraid if we notice any change. And in fact, a lot of changes are not breast changes, are even not breast cancer. Very often we see something and it's not, but it's not for you to sit at home and decide it's not. It's best done in hospital when it's been thoroughly investigated. So let's seek help when we find any changes where we have opportunity to be screened. Let's screen, let's do our breast self-examinations, and let's follow on whatever we find and be compliant with whatever treatment we need to go through.
Fantastic. Thank you very much. So I just shared a few of the thank you messages that is coming from our viewers. And I'm always in awe of the doctors. Thank you so much. I know there are 1,001 things you could be doing Sunday afternoon, Sunday evening, but thank you so much for making a date with us. Oh, Vincent. Thank you, Vincent, for watching. Thank you, Prof. Audrey. Thank you, Pastor Jacqueline. You've been missed, Thank you, Pastor JPC. The people you tagged, we're truly grateful for you tagging them. Now that the program is over, I'll just urge you to keep sharing. Bishop Bullis, I think because you logged on first, you managed to recruit Nigeria. So tonight, Nigeria was winning. Thank you, Bishop, for joining. It's a blessing that you started with us and you stayed all the way through. God bless you. Right, so we've come to the end of our program. Now, our next session of time with the doctors, I find truly exciting because we are going to be discussing raising special needs children. Am I right, Prof. Lai?
Yes.
Could you just tell us a bit more?
Yeah, so, we'll be talking about raising special needs children. There are so many people in our communities that have special needs children, either whether it's autism or Down syndrome or all kinds of other challenging problems that children may have. And unfortunately, in developing countries, we don't have many resources like we do in the US here or in other developed countries. And I think it's going to be very informative. We have some people who have personal experience and how they've been able to deal with some of these challenges. And so it will be very helpful So just book a seat next time we come on in a few weeks to talk about dealing with special needs children.
Lovely. Thank you so much. God bless you all. Shalom.
Bye-bye.
Thank you.
So can we stay on? Don't
Yes.
log off yet.